Okay, so the treatment of sleep disordered breathing, we have 5 treatment alternatives. We've talked ad nauseum about CPAP, everybody knows what it is. We've talked about surgery. We have nasal surgery, we have palatal surgery, and we have bimaxillary reconstruction, among other surgeries. We have lifestyle changes, we haven't talked about that. We all know what they are. And interesting, I think possibly some of the lifestyle changes are what Leo's talking about as well. And oral systemic health really is lifestyle change. And so that's good stuff. And then we're talking about oral appliances. And now there's a new category called other. And other is neural stimulators we've got to talk about. We can talk about the nose vent. Rick already mentioned nose vent. And then there's drugs. So, okay. And so the point is you've seen the nose vent. And the nose vent basically prevents full exhalation. Now, maybe better you can understand that by keeping by preventing full exhalation, we have enough oxygen in the air that's retained, but we don't expel as much carbon dioxide. And so the thing about the nose vent is, however it works, it works. But the carbon dioxide probably has nothing to do with the design of the device. It's just I look at it and I see that, oh, well, maybe that's the mechanism. But the mechanism ultimately is it lowers the apnea-hypopnea index. And so then we have the electrical nerve stimulation. So in reality, they actually do surgical procedure. They put the wires in under the skin and they implant this battery-operated device. They set it. And then what it does is it stimulates the hypoglossal nerve. Now the interesting thing about this procedure is that it's unilateral. And so in my mind, this is the way my mind works. I say, if it's unilateral, the tongue is going to go like this. It's going to go to one side because it's unilateral. If we had it in both sides implanted, the tongue might want to come out. And so I met a guy who had one of these. I said, so it works on one side. Is this what happens? Like this. And he goes, yes, it does. So I thought, okay, maybe one of these days they'll get to putting one on each side. But I don't know, I just feel like that. It's just weird. But okay, that's just another tool. The other thing about the nose vents and the electrical stimulation is they're not getting the results like they're getting with CPAP or oral appliances. We are getting a better result. The thing is, what happens with these is the patient is more an object of cure. This is installed, it goes off, they do turn it on at night, but you know what, they're an object of cure, there's less involvement. So, okay, is involvement of the patient in their own health care such a bad thing? A lot of people would say that's a good thing. So, who knows? Okay, so oral airway dilators. There are about 100 oral devices for treatment of snoring and obstructive sleep apnea that have 510K FDA clearance. The design principle, the more room created for the tongue and the mouth, the less likely it is to collapse on the airway. That's Alan Lowe from British Columbia. And the principles on which an ideal bite registration position for an intraoral sleep appliance is based. We said the maximum vertical height that the patient can tolerate keeping their lips together unstrained. The maximum comfortable protrusive position with the lips together. We're looking to have this defined by the neurological system by doing manual muscle testing. However, the point we're making right now is when the lips are together, the patient is nose breathing. Okay, so wearing an intraoral appliance alters the depressor muscles, the tongue affects the position of the hyoid bone, and it works differently in mouth breathers than nose breathers. And we said that this is what it does. What's the role of the dentist? The role of the dentist in patients with an apnea-hypopnea index, let's say you screen the patient, so and it's over 10, the role is to refer the dentist to the specialist, and treatment by the dentist of obstructive sleep apnea with an oral appliance is by referral from a sleep specialist. And of course, there's the avenue of prevention. Prevention is important. We're going to talk about that tomorrow morning because really every case that we see of adult apnea, almost every case is a failure to diagnose and treat and prevent the problem in children. Okay, we're going to put a Moses appliance in. And that Moses appliance is like giving the patient a crutch for the rest of their life, because we're orthopedically correcting the problem as long as the crutch is in. If you correct it in a child, you cure it. You cure it, you prevent it, and you cure it. For the rest of their life, they're in good shape. Big difference. Huge philosophy difference. And so, anyway, that's the story. Prevent the problem. Yes? I'm answering that tomorrow. That's my course tomorrow morning. Okay, so what are the indications for an oral appliance? Referral for oral appliance therapy from an MD. Primary to heavy snoring, apnea, hypopnea index less than 10. Mild to moderate obstructive sleep apnea. Severe with a failure of CPAP. When do you do it? Well, when the CPAP's failed, or when they have absolute intolerance to CPAP, or the failure of the UPPP. I told you about the surgery where they, honk or they regurgitate nasally. That's failure. But the point is, if they still have apnea, then we're the player. And so the other thing was the use of appliance during travel, because they don't have electricity or they don't want to schlep the CPAP around. And then the other new use that we're talking about is use of the oral appliance therapy in conjunction with nasal CPAP, because that way you can cut down the pressure and make the CPAP more tolerable. How does it treat it? It prevents collapse of the airway, it advances the jaw forward, it corrects dysphagia, it increases vertical dimension, it increases volume of space for the tongue. We've talked about all this. What's the focus of the dentist? Breathing, tongue, mouth, jaw relationship. Okay. And so collapse of the tongue is in the oral pharynx. It can occur in any region, the velopharynx, oropharynx, or hypopharynx. They work best where the collapse occurs in the oropharynx. Okay, so we saw this picture already, and this 10 seconds is, when it's 12 seconds, is actually exceedingly long to not having any air passing. And in many of your cases, if you look at your study, you'll see on one particular individual, it averaged 30 seconds. Average 30 seconds. That's almost 3 times this. And so it's horrific to not have any air flow to the tissues for that long a period of time. And we said the clinical features alone can't identify it. The more room created for the tongue, the less likely it is to collapse. How do we gain tongue space? Mandibular advancement, tongue advancement. We talked about suction of the tongue retaining device, and we talked about non-tongue restrictive MADs, and we have vertical opening of the jaws. Screening by dentists for obstructive sleep apnea. Diagnosis is determined by a PSG, must be confirmed by an MD. And so, what are the parameters? Okay, let's talk about compliance. We said the studies report an 80% compliance with mandibular advancement devices with oral airway dilators, but the CPAP study reported 46% compliance. So, and every day you don't wear it, you get back to square one with a CPAP. And so we define compliance as with an oral appliance as all night, every night. And they say that CPAP compliance is defined by at least 4 hours per night, used on more than 70% of all nights, and that calculates out to 20 hours per week is their definition of compliance. If you set your standards low enough, you achieve compliance. Cribbs and Pack wrote an article, sleeping without CPAP for one night reversed virtually all the sleep and daytime alertness gain derived from sleeping previously with CPAP. Mandibular advancement devices, oral airway dilators are preferred over CPAPs by patients because they're more comfortable, more portable, more socially acceptable. They make no noise and fewer undesirable side effects such as dryness, bloating, nasal congestion, and runny nose. How do we measure this? And so we have already discussed the fact that the ideal ambulatory device measures all these things. We went over it. And then let's talk about other oral appliances. So the original tongue retaining device. This is a one-size-fits-all store-bought. This is called a Snorex. And basically, this here ring goes between the nose, around the mouth, extraorally. And then this goes in, this is the bottom, it's for the frenum of the tongue. The tongue is put in, and then the tongue hooks on these so that the whole device isn't sucked back in, and then it's held in place. And you create the suction in the mouth, the tongue stays in there, and it keeps it sucked out. Not comfortable at all. Very, very short period of time it was used. The next thing we have is a custom fitted one. This is basically a positioner. They create enough room between the arches recording the bite for the tongue to come forward. They create the bulb in silicone, and they suck it, and so that device, again, the tongue physiologically doesn't belong in front of the lips. It's very uncomfortable, and this also very effective device, very short-lived device. And so then we have the Aveo. It's a store-bought, one-size-fits-all. It's called, I don't know what it's called, Aveo. And it's an they're advertising it as actually not even for apnea, they're anti-snoring aid. Okay, selecting the proper oral appliance. So we have mandibular advancement devices. In the mandibular advancement devices, we have custom and we have non-custom. So in the custom, we have a tongue retaining device. We have the tongue restrictive, two kinds, tongue restrictive and tongue non-restrictive. So this is a boil and bite. You put this in. It's non-adjustable, but it's a tongue, it's a closed anterior, restrictive anterior. Then this is another version. This is was not terribly effective because the rubber bands didn't hold for very long, and two layers. The outer layer is hard plastic. The inner layer is some sort of a ethyl vinyl acetate. They never stuck together, and so this was also reasonably short-lived. But you boil it, and then you put it in the mouth, and you correct the bite. And then by changing rubber bands, you have the ability to protrude over a ratchet device that sits there in plastic. And so this, again, restrictive anterior. And then we have devices that look like that. I believe this is called a NAPA, nocturnal airway patency device. And this is restrictive anterior, non-adjustable. Now, there is an issue. And Alan Lowe, the famous dentist from British Columbia, the famous orthodontist who's published hundreds of papers, feels that no matter what, all oral appliances move teeth. Now, he did these studies that they move teeth on the basis of the Clearway. The Clearway is his appliance. Now, I really believe that once you introduce a clasp into an appliance, just as you put a clasp on a removable partial denture, teeth move. And so why I claim that we don't have movement is because on the upper we have a retainer. There's the retainer in green. This retainer is polypropylene, and the point is this is a retainer. The teeth don't move on the upper. End of story. There's no way they're going to move. Now, the point is on the lower, again, all teeth are touching something. So, but when we make the Moses, you got one in your hand there, so I don't have to show you. But when you make the Moses, here's the way they do it in the laboratory. First, they survey the case. And then when they survey it, they block out all undercuts in wax, hard tissue and soft tissue. And so when this thing goes down, you saw it today, in 13 out of 15 cases, click, and it went down. That's no accident because they surveyed that case and they blocked out the undercuts, and so it goes click. If they've surveyed the case and it's got a path of draw, and the path of draw is parallel for all teeth, those teeth aren't going to move. Come on, how are they going to move? It's the same as the retainer for the other. It's actually better because once you engage that polypropylene, there's undercuts, and so the undercut's good. But when they survey that tooth and put that down, you got to tell me how these teeth are going to move, and I'm not seeing the movement, period. If you give them a lousy impression and there's bubbles and it pushes and pulls, that could happen. We're all going to give them good impressions. That's part of the deal. Because when you give them good impressions, you guys are an exceptional group, it goes click because you made the effort to do it right. And so I could say that, and I'm not patting on the back. When these came in, they came to our office, I looked at every single one of them, and they were excellent impressions. I'm really proud. And because, you know, I want to make sure that these things that go out, that have my name on every single one, I want to make sure they're good. And so I looked at them. But the point here is I'm making is clasps move teeth. There's no clasps. I believe that, and I have never seen evidence of tooth movement. There's a guy called me up once. He was with Clinical Research Associates of all things. He says, you opened a contact up. But then, again, when I looked at the impression, really, this guy didn't send such a good impression. And he had bubbles. And the bubbles that they incorporated, it shouldn't have, but the bubbles were moving the teeth. But bubbles were based on the fact that the proximals weren't, the impression wasn't good. So maybe I'm copping a plea, and it happened once out of 10,000 cases. Okay, this is the Clearway. And in this device, it's tongue restrictive. The tongue cannot advance to the lips. You can see, they got plastic here, they got plastic here, they got plastic here, and this is hard plastic on the upper. This is not a 0.4 of a millimeter suck down. This is hard methyl methacrylate. And this is what the Clearway looks like on the upper. So you've got this big thing here, you've got this methyl methacrylate, you've got this device here. This is the advancement device. And so you saw, you don't have anywhere near the tongue space, and you can't get the tongue to the roof of the mouth, and there's clasps in all this. There's ball clasp virtually between every tooth. He's claiming that it does move teeth. Now, he's got an interesting argument for the fact that they move teeth. Rick was talking about that 50% of the time, the move is neutral. It just doesn't affect the occlusion, but they've moved. 25% of the time, it's really good movement that occurs, and 25% it's harmful. The answer he gives is breathing is more important than eating. Yes, your teeth move a little. Your dentist, get over it. You're treating breathing. This is life-threatening, life-saving. Get over it. That's the answer. Get over it. But I don't think we move teeth. So that's another point. But I guess occasionally, you may see a case where the patient doesn't want to go beyond, retrusive beyond edge to edge. They don't want to go back to centric occlusion. This is the step plane of occlusion. They got dysphagia. They don't want to get back. And so they don't get back. I got over it. I say to them, this is almost, one guy said, you're being facetious. I gave him this line. I said, Albert, I have good news for you. The good news is I cured your apnea problem. The good news is I also cured your jaw problem. So the guy says, are you being facetious? I said, no, I cured your jaw problem. He said, well, what do you mean? I said, you had a TMJ problem when you came in here, and now you're in a perfect position, your jaw doesn't want to go back, and you're comfortable, right? He says, you know, you're absolutely right. He says, I talked to my daughter-in-law who's a dentist, and she said that by you doing that, you're the guy that got rid of my headaches. She said, I had a headache every day all my life, and I got rid of the headaches. So, okay, so I'm not kidding, I'm not being facetious. So he says, now, I want to chew on my back teeth. I said, fine, we're going to make you 8 crowns. Okay, this is really a nice case. But that's the point. So you do the 8 crowns. Why? Because you know how to do it. You know why it needs to be done. And when you do that, yeah, you'll have to make him another appliance, or you'll have to do a huge remake of the other one, remodeling. I would just remake it. But the point is that this guy was serious. He got rid of the headaches. He wants to eat on his back teeth. Fine. Now, I've had this happen, again, I've done thousands of cases, but I've had this happen 3 times in the past. One is a professor of molecular biology at Rush. He's head of the department. The guy is a hugely intelligent guy, and he says, you know, so I eat like a rabbit. He says, but I eat. Look at me. I'm healthy. You cured the apnea. I feel better. I'm not tired. I do my work better. I'm not going to rebuild my back teeth. And the other guy, same thing. The guy was a Yale professor. The guy headed a humongous foundation. And he says, hey, I can eat. The problem came, the guy, he needed a crown on number 19 with a step plane of occlusion, and he had no posterior occlusion. So he goes, This guy, big shot, he's got to go to his New York prosthodontist. So he goes to his New York prosthodontist. The guy says, you need a crown on number 19. Calls me up. He says, where the hell am I supposed to build the occlusion? This guy doesn't touch anything. So why the hell are you asking me where to build the occlusion if he doesn't have to touch anything, jerk? So build it. Make the contacts even to 18 and 20. And don't bother me. I mean, what kind of questions are that? You're the prosthodontist. But anyway, okay. And so the point is that these people are over it. Breathing is important. Daytime function, that's important. These guys are happy. It happens. And you know what? It changes everybody's theory on posterior occlusion. It's instead of all the teeth meeting at the same time. So they can eat, they can talk, they can function, they can breathe. Isn't that enough? Why do we have to have all the teeth touching at the same time in the posterior? So I'm rethinking it. And then we were at a meeting at the Academy of Craniofacial Pain, and Okeson was speaking. So I went up to him. I said, Jeffrey, what about? He says, you see that too? I said, yeah, I see it. He says, you know, I see it, and I have to tell the patients about it. They don't know what's happening. Well, you got dumber patients in Kentucky probably because, you know, if your back teeth don't meet, the patient knows it. No, I tell him. I say, you know, your back teeth don't meet. Okay, but he knows about it too. I said, what does that do to your theory on occlusion? He says, I'm still thinking. I'm rethinking it. I'm still thinking about it. And you probably know him well enough. He asked him the same question. What are you doing about, what does that do to your theory on occlusion? Okay, he's rethinking it. That's huge. Fine, I agree with you. Let's rethink our theories of occlusion. This is important. What we do is very, very important. Does this happen all the time? No. Thank goodness it doesn't happen all the time. It does happen occasionally, but certainly not all the time. And I think Richard has a question. Give him a microphone. Okay.
Just a thought. First molar occlusion is not required anymore to keep and protect the TMJ joint as long as they're wearing the splint at night?
Mm-hmm.
Is that what you're saying?
I'm saying as long as they're wearing an appliance to protect the jaw, that the occlusion is, they have an occlusion, but they just have an anterior occlusion. They can't get back to the posterior occlusion.
No, I understand. A pterygoid short and everything's happened. But so now the question I have is, are they wearing the appliance 24/7 or only in the evening?
No, they're perfect during the day. Pain-free, asymptomatic, they can even eat. They only wear the appliance at night, and it's working fine.
Okay, well, based on this observation, do you feel that it's not necessary then to have a 24/7 occlusion and that they're going to be fine just wearing the appliance 7 to 8 hours a day?
Yes. Yes.
And are they wearing a Moses appliance or are they wearing...
Could be any appliance.
Okay.
This happens. It's not exclusive to the Moses. It happens to everybody who's doing oral appliances.
So an anterior reposition?
Yes.
Okay, you've answered my question.
It is a muscle deprogrammer. That's the story. Okay, so here we have tongue restrictive, and if I'm not mistaken, this is maybe a tab 3, but the point is we have tongue restrictive. This is tongue restrictive because still you can't get the tongue to the lips. Okay, and then we have tongue restrictive because in this particular case, you can't get the tongue in front of the hook. You also can't get the lips closed because you got this little goober sticking out between your lips. But the point is, hey, the literature says that this works too. And so it works. So basically, I think that, wait, we have the Moses and you can get the tongue to the lips, but what are the biological indications for a tongue restrictive sleep appliance? So I think about this kind of thing. And so, because I am who I am, I think of answers. And so I'm here to share my answers. What are the indications for a tongue restrictive device? And I'm proud to tell you, I have a good answer. That's the indication. This guy could wear a TAP 1 and have absolutely no problem. In fact, he likes his TAP 1 so much, he's just telling me how much he likes it. Okay, and then we have this one here, and I'm wondering, what's the indication? I got it. I figured it out. Here's the indication. Right there. You have to have a forked tongue again. But this one here would work also. Okay, so then we have non-restrictive open anterior. And that's the Moses. And so, open anterior. Is that important? I ask myself, is that important? I think it's important. So here's the story. This is the other version, the black and white version of the picture you saw with the golden airway. Here's the sagittal section of the airway, and they measured from the second cervical vertebrae. So the answer to the question you were asking earlier, were you asking me about vertebrae? Somebody about the vertebrae. This is C1, C2, C3. Okay, and so the field of action is between 1 and 3 that the oral airway comes to. Okay, so from the bottom of the second cervical vertebrae, what we see is 10.75. This is lips together, teeth apart, tongue in the roof of the mouth. Here it is, appliance in place, tongue in the roof of the mouth, lips together, 14.75, 14.75. So this is roughly a 40% increase in sagittal dimension of the airway with the appliance. Okay? 31, lips together, teeth apart, tongue in the roof of the mouth, rest position. This is appliance in place, 39.75. So it's a 25% increase in the lateral dimension, and it's a 40% increase in antero-posterior dimension. This is huge. Put the two together and you have almost a 80% increase in the size of the airway. But look at it coronally, 18.75 to 29. This is almost double. 21 to 39, huge, almost double. 24 to 34.75. So we're looking at some dilation dimensions of a huge magnitude. And that's what we see when you put the whole thing together in a three-dimensional picture. So we have oral airway dilation. We have open anterior. Do you understand the importance of open anterior? People have tongues like this. We want to keep it in the mouth. People have tongues like this. And people have tongues like this. Would you want to put a tap one in place of it? Not only, you want to see the joke here? That's a tongue tie. There are mandibular advancement devices and there are oral airway dilators. Only the Moses has been shown to be an oral airway dilator. So, in selecting an appliance, you have definitive choices. I want to make that clear. You have the choice of the Moses, the Rolls Royce, or something else. These are your choices, and this is what they represent. So, let's talk about protrusive tongue reflexes. There are protrusive tongue reflexes. So, what I found in the literature is that there are 4 protrusive tongue reflexes, and there's 1 non-retrusive tongue reflex. So, let's look at them, because the resource that I have is Arthur J. Miller of the University of California in San Francisco, and he wrote an article I will probably show you, and in any case it's referenced and it's in your folder electronically. You can reprint the whole article. The reflex is defined as the sum total of any particular involuntary activity. Specific sensory inputs can subconsciously induce motor responses that have reciprocal effects on different motor neuron pools. So the important thing is you're doing a sensory, like in this case, sensory trigeminal in the tongue, and it's affecting the reflex in the hypoglossal or the glossopharyngeal. And so the point is you're doing different stimulation by involuntary central nervous system circuitry. And it's not like you can find a sensory motor on the same nerve. It's not like a continuation of the same pathway. At some point, the reflex has to go through the central nervous system. Okay, reflexes, relatively hardwired circuits through the central nervous system to control a set of often antagonistic muscles for coordination of a given response, such as a swallow. The motor neurons and the Golgi tendon system are part of a neurological feedback loop for maintaining muscle tone. A reflex reaction is conditioned not by one reflex arc, but many. Coordination is part of the reflex. Most complex reflex we have actually is a swallowing reflex. And that's extremely complex. And it's all based on coordination. The main secret of nervous coordination is compounding of the reflexes according to Sherrington. Stuff is not new. When I told you about the non-parallel being ascending, descending, and the parallel being ascending, that's also Sherrington. And Sherrington won his Nobel Prize in Physiology in 1915. So this is nothing new sometimes. Learning is involved in establishing many reflexes. Reflexes elicited from stimulating the oral region alter recruitment of lip, tongue, and jaw muscles. The type of sensory stimulus determines the type of reflex elicited, from simple reflexes to complex behavior affecting oral and pharyngeal regions. Motor neurons responsible for the reflex activity of the head and neck are located in the brainstem, medulla, pons, and midbrain, lower brain levels. You don't think about these things when you're doing them. They're automatic. They're hardwired into the system. So, in the tongue, very, very complex muscular organ, because in the tongue we have extrinsic tongue muscles. The extrinsic tongue muscle attaches to at least one bone and alters the shape of the tongue. Then we have intrinsic tongue muscles. Intrinsic tongue muscles have the origin and insertion in muscle. Now think about this. All the muscles we usually deal with in the body, origin in muscle, and bone, insertion in bone. Now we're talking insertion in muscle, origin, insertion in bone, origin in muscle. But then we also have origin in muscle, insertion in muscle. And we have a lot of these. And that's what the tongue is about. And so we have some very, very complex motion of the tongue. And so when you want to alter the shape of the tongue, that's extrinsic. And the intrinsic tongue muscles protrude, retrude, and move the tongue laterally. The chief tongue protruder is genioglossus, which is an extrinsic muscle. Genioglossus is attached to what bone? The mandible. Okay, changes in mandibular posture can have a direct effect on tongue activity and may relate to the role of the tongue in airway maintenance. We said low tongue position, mouth breather, smaller airway. Tongue in the roof of the mouth, tongue against the front teeth, larger airway, nose breather. Genioglossus is the main tongue protruder. It's an extrinsic tongue muscle. And interestingly enough, the genioglossus electromyographic activity is in phase with respiration when awake or in a resting state. So the genioglossus is doing the same thing your diaphragm's doing. Neat stuff. Reflexes elicited from stimulating the oral region alter recruitment of lip, tongue, and jaw muscles. The type of sensory stimulus determines the type of reflex, from complex behavior from simple reflexes to complex behavior affecting oral and pharyngeal regions. So tongue reflexes are activated by motor neurons from 3 cranial nerves, hypoglossal, trigeminal, and glossopharyngeal. So we have the jaw hypoglossal reflex. And the jaw hypoglossal reflex says that opening of the mandible increases the activity of genioglossus. Then the position of the mandible affects the tongue posture and protrusion. And the forward protrusion of the posterior part of the tongue helps maintain a patent airway. So stimulation of the inferior alveolar nerve, trigeminal 3rd division, stimulates firing of the hypoglossal nerve to protrude the tongue. So passive opening of the mandible by 4 to 6 millimeters stimulates this reflex. Open anterior design in sleep appliance facilitates this reflex. If you look at that reflex, you can't do it if you got a tap in the mouth. You can't do it if you got a clearway in the mouth. It's just not going to get forward. It's got no place to go. You can't stimulate the reflex. So you need an appliance in which you can stimulate the reflex. All you have to do to stimulate the reflex is make the appliance, because the design is built in. So if you put a Moses in, you're stimulating this reflex. Okay, and so what it says is open the anterior, and passive opening by as much as 6 millimeters stimulates this reflex as long as the appliance is in place. As long as this appliance is in place, the tongue instinctively wants to come forward, and you got room for it to come forward. It's good stuff. It's nice when you have the appliance and then you read the literature and you've already done it, because it's hard to figure this before you've done it. A jaw opening in the range of 4 to 6 millimeters elicits reproducible genioglossus movement which lasts as long as the jaw is open. That's the jaw hypoglossal reflex. We also have masseter hypoglossal. Now, masseter hypoglossal is an inhibitor of retrusive tongue muscles. Again, Arthur J. Miller. How does that work? Passively maintained jaw opening beyond respiratory position elicits reproducible inhibition of muscle retrusion. So the masseter hypoglossal is a retrusive, non-retrusive tongue reflex. Okay, we also have the lingual hypoglossal reflex. Mechanical stimulation of the tongue surface inhibits or elicits different tongue muscles depending on where the input originates. And this can be facilitated by a prior conditioning reflex. And so what we have is a series of exercises. And this is the series of exercises. So we give the patient the appliance. You've already had your appliance. And now I would sit down and I would hold the appliance up and on the models, and I would say the following. Experience the feeling of your tongue, create a suction in your mouth. With the suction in your mouth, experience the feeling of your tongue touching your lips. Can you feel that? Experience that feeling. You feel your lips, right? You feel the crack between your lips? Yes. Against the front of your tongue, the tip of your tongue? Yes. Okay. That's the exercise. That's all you're going to do, because that's stimulating the reflex. And so, experience the feeling. Then we say, second, experience the feeling of your tongue on the smooth surface of the retainer over your upper front teeth. Okay, and so it's smooth surface over the front teeth. But we changed that a little bit because now we have the tongue dimples, because it's a stronger stimulation. So you felt those if you have your little appliance. Experience the feeling of your tongue against the tongue bumps, and that's more distinctive. That's registering stronger than just feel the smooth edge of your upper teeth. So we now have the tongue bumps. And then experience the feeling of your tongue against the cut edge of the upper. Different part of your tongue, right? Yes, good. Experience the feeling of your tongue against the palatal rugae. We talked about palatal rugae. Experience the feeling of your tongue against the palatal rugae. Okay, and I say palatal rugae are there for the stimulation of a clear nose. Push, suck, push, suck, push, suck. 4 times, series of 4 times. And if you do that, we're going to repeat the whole series of exercises 3 times. By the time you're done with these exercises, you should feel some nose clearance.
What's the difference between 3 and 4?
The difference is that I didn't say feel the palatal rugae, and I mistyped the whole thing. I must have done this too late at night. And so number 4 should be experience the feeling of your tongue against the palatal rugae. Suck, push, suck, push. I think I missed that. Sometimes you do these slides late at night and you think you said something you didn't. Experience the feeling of the lower tip of your tongue against the lower anterior teeth. Can you experience the edges with the lower tip of your tongue against these lower teeth? Yes. Shake your head. Can you experience the feeling of the bottom of your tongue against that smooth, shiny plastic? Yes. Okay. Experience the feeling of the lateral borders of your tongue and the groove between the upper retainer and the teeth. There's a deliberate groove in there and there. And why do I want that groove? I want that groove because the sides of the tongue are on the sides of the mouth. So now we've got the tongue against the palate. We've got the tongue against the bumps. We've got the tongue in the roof of the mouth. The whole tongue is in the roof of the mouth. The tongue is in the roof of the mouth. Guess what? The nose breathing. So we're getting everything done at once here. This is the whole thing. And what? It's really nice because the design facilitates this kind of a tongue position that's beneficial. So, experience the feeling in the lateral border. Okay, and there's the front edge of the groove. So now we have glossopharyngeal hypoglossal reflex. Glossopharyngeal nerve stimulation, posterior third of the tongue, induces tongue protrusion. So I got this in there, and I got this from Miller. But the more I think about this, the harder it is. I thought at one point that I had these lingual lifters, I call them. Oh, and there's another view. These are the lingual lifters we added, and I tried it. And the lingual lifters were hopefully to get the vertical posterior third of the tongue. Number one, I now don't think that you get the glossopharyngeal nerve. The other thing is, having done this on me and a few others, it's not very comfortable. So we took it off. But we do have the tongue-tongue reflex. And the tongue-tongue reflex says that touch or stroking the tip of the tongue orients the tongue toward the stimulus. The more intense the stimulation, the higher the probability of tongue movement. And what that's involved in is, for example, if you ever see where the baby, if you take a little drop of sweet liquid like fruit juice and you put it on the tip of the tongue, the tongue comes forward. And that's tongue-tongue reflex. So can we use tongue-tongue reflex? Yes. You got tongue bumps, the tongue dimples in the front. That's what they look like now. So I think when I did that, that's how I did it. John's probably got a better way. But I did it, I just put the blue block out on there, and then I sucked it down, trimmed it up, and it looks like I got 6 of them there. What do we put, 4 of them now? I don't think it makes any difference. You got tongue bumps, huh? 4. Okay, as long the tongue bumps are tongue bumps. I don't really think it makes any difference. But if you want 6, ask her for 6. I don't think you charge any extra for the 2 extras, right? I'm hoping. But anyway, it doesn't make any difference. Tongue bumps are tongue bumps. And that's the way I did the tongue bumps when I was trying to develop it. Yes, that makes a difference. When your tongue goes to those and plays with those, it's incredible. You'll see. Mechanical stimulation of dorsal surface of the tongue will induce the same reflex as direct stimulation of the lingual sensory nerve. Coordination of the reflex activity of the tongue relies heavily on exteroceptors on the tongue surface. And so the thing with these is, what I find is that, again, I could do a study, but I don't do controlled study in my office. I've never, in 44 years of dentistry, have a patient come in and volunteer to be a placebo. So the fact of the matter is, I don't think it's fair to ask them to be a control. If I know that I've got something that is beneficial, so here's the way I played this. So I took this to Northwestern, and I said, hey, here's my series of exercises, here's the model, here's how it works, what do you think? Is this legit? Are these reflexes legit? Yes. Here's the reference. Read it. Okay. Yes. If this is the way this is what it takes to operate a reflex, and this is the reflex, yes, you're stimulating the reflex. So how would I do a study? So I went and I hit a bunch of people up. And the way I would do the study is I would give the patient the appliance. You got the appliance now. And I'd say, okay, go home and try it. Then we might do a study. And then maybe another half the patients I might say, okay, 3 weeks later, we come in for tests. Let's test and see how your appliance is working. And then I do nothing to adjust the appliance, but I give them the exercises. And then I test them in another 3 weeks. And if they're better, then we can possibly attribute it to the reflexes. So I think, wait a second, is that the way I want to deal with my patients? I think it's basically dishonest. I think that these reflexes work. The reflexes are in the book. I didn't make them up. And so what I do is I say, okay, what I can tell you is that if I give the patients the exercises from day 1, and they do them, because I asked, did you do them? What exercises? Did you give me exercises? No, 6 months. If that's the answer, I assume they didn't do them because they don't remember them, and they didn't do them. And then I test, because in 6-month recall, if they show, they get a metabite study. And if the metabite study is worse, I recommend the exercises. The metabite study is better. Invariably, the patient says, yes, I do those exercises. I still do them every night because they work. And so, again, it's a clinical study. And that's why what we do is called practice, because it is practice. It is clinical study, but it is not controlled clinical study, because no one has ever volunteered to be a placebo. They want your best clinical effort, and they get my best clinical effort. And so my research is done at the clinical level just like that. And I don't study controls. So in my mind and in my hands, these work. I would say try them. They're certainly benign. They're certainly non-invasive. They're certainly not harmful. If you find that you test your patients after 6 months and they're better than they were when 6 months after you dismissed them, if on a recall they're better, there's a good likelihood that it's because they did the exercises. At the end of 3 weeks, the exercises might not be working. Okay, why do I say that? Because, listen, if you want to train a golf swing, it took Tiger Woods 3 years. When he first decided he wanted a different golf swing, it took him 3 years to learn a new golf swing. 3 years. You hear that, Mike? 3 years to learn a new golf swing. Okay, the point is a new golf swing takes, a golf swing itself evolves around 1,300 neurons. Okay, swallowing involves around 5,700 neurons. It's the most complex activity we do. So you're trying to train an activity that takes 5,700 neurons versus a mere golf swing, which is complex enough, at 1,300 reflexes. So the point, circuits. So the point is, we're doing something that's very complicated, and it's not something that's going to happen in 2 weeks or 3 weeks. It took Tiger Woods to learn a new golf swing 3 years. So if you give them 6 months and you see a better result, it's reasonable that they're doing it. And again, can we prove it? No. Can we prove he's you know, again, better? It's like, again, you get a mouth guard and you say, this is terrific. You put it in and the guy hits a home run. Does that prove it works? No. You got to do a different range of study, but there's a lot of subjectivity to this research. We're dealing in a field that's just not going to lend itself to an academic study just like that. You have to pick it out, dissect it, figure it out, and by the time it's been dissected in the past, this kind of research falls apart. It's not doing its job. What we do is good research, and yes, it's practice. Okay, so here's the exercises again. They're printed on your form, and the resource is that, here's the reference. Here's where I say it. Listen to me. If you taught a patient to swallow correctly with myofunctional therapy and when they were kids, and they swallowed correctly during the day, they maintained the correct swallow at night. So reflexes can be trained during the wake state and persist during the sleep state. Patients were taught to play the didgeridoo. British Medical Journal, December 2005. They play the didgeridoo and reduce the apnea-hypopnea reflex, apnea-hypopnea index 50% from an average of 22 to 11. They taught the patients to play during the day, and the reflex activity persisted at night. Gomeres and Draeger and Henta taught the patient oral pharyngeal exercises based on myofunctional therapy. They taught them during the day. The change persisted at night. Again, about the same as the didgeridoo study. 50% reduction, somewhere in the range of 22 to 11. So you don't cure it, but you get an improvement in reflex activity by training. There's 3 pieces of good evidence. So the question you could legitimately ask, most legitimately ask, is, do your exercises relate to reflexes? And if you read the article by Miller and you agree that it does, then again, I'm not going to do the kind of study they did. You can do it if you want, and maybe Gomeres wants to do it, but basically this is an expensive study and takes a lot of time, and you need the right controls. So, and this wasn't so controlled. Okay, how to make a better Moses. So let's look at it. Somebody came up to me and said, hey, why do you want full lingual extension? And so when I saw this at one point, or when I got this on a case, I made the outline, I sent it back to John, and I said, first of all, I want these teeth all covered. Because, hey, what's going to happen to this tooth if it's not covered? That's, again, I don't want movement. If you don't cover a tooth, you can get movement. The other thing is I want full lingual extension. Why do I want full lingual extension? Because I want the tongue in the roof of the mouth. I don't want the excess room down there. But if I make it short, like that one was, then the tongue is going to go down there and play with it and lift it, and I've defeated my purpose. I don't want the tongue on the floor of the mouth playing with it. I want that thing blocking the tongue from going down there. Full lingual extension. So, full lingual extension. Here's a different model, different example. Full lingual extension. And for some reason, you got to watch carefully because I think this is a different case here. And again, there's not full extension over that back tooth. I want full extension over the back teeth. So, now Gloria mentioned the subject, and certain trays get better lingual extension. These trays we use, they seem to get better lingual extension. And so that's the reason I use them. One of the things I will point out to you is that I have the onerous task for my assistants of drilling the holes bigger, because if the holes are as small as they come and as few as they come, I find they separate. So I have them make the holes bigger. My craziness. But I haven't seen a tray shaped like this. I think she said these are dentorum trays. Cover the oh, that's another thing. If you see the tori, I try and cover the tori rather than go short of the tori. If you go short of the tori, these things are way more breakable. Cover the tori. You don't want the tongue down there. Cover them. Make less room for the tongue in the floor of the mouth. That's the whole point. So this one here, again, you can see very easily that it's underextended lingually. The tongue can position itself on the floor of the mouth, lift the appliance, and if it's down there, it's restricting airway space. Okay, then we want the anterior dimples, or you don't. I'm sure they'll not put them in if you request that they don't put them in. While I say the lingual lifters didn't quite meet my satisfaction, these do. Again, the big thing is watch for that and tell them about it. Okay, any questions? Yes? Microphone, microphone. Good looking, good paying attention. Get her a microphone. Who's typing these microphones?
How do I treat my edentulous and partially edentulous patients?
What?
How do I treat
an edentulous patient?
Or a partial edentulous patient with hemosis? How do I do that?
Well,
because I have a lot of them.
You have a lot of them.
Mm-hmm.
All I got to say is how stable are the teeth, and what will they hold the weight? Will the mandible, will the maxilla support? In other words, the maxilla is supporting the mandible. So it's a question of, do you have the support in the maxilla to hold the mandible up? If you think there's too much pressure of the mandible pulling down, you could conceivably get mid-face. The whole thing could retract, which I don't know. But if you have enough teeth on the upper to hold it, then I think you can do it. The amount of teeth on the lower is less important. You do need some teeth here so you can hold. But again, this is a question. In an ideal world, yeah, okay, totally edentulous.
For example?
Totally edentulous, I have made these. When I make them on a totally edentulous patient, typically, these patients survive and they wear these teeth and they're awful. And you wonder, how can you do that? And so you could make it over and be adjusting sore spots like you're doing a denture. I'm not looking to make them a denture. I'm looking to make more space for the tongue. My philosophy is I make a Moses over the dentures. I take impressions of the dentures, record the bite, and make it over the dentures. Leave them in. Tell them to clean them every day. I leave them in. If there's no retention at all and it's totally flat, my best advice, what seems to be working, is they're putting in a few implants, 2 implants, and they seem to be getting results. 4 implants is better than 2, but they're putting a couple implants in to hold them.
Well, I had a patient with implants in the mandibular, and I made the Moses over the denture.
Yes.
But it was gliding away.
It was what?
The Moses was gliding away from the...
Pulling away?
Yes, there was no retention.
So how about if we put a rubber band or an O-ring somewhere on an implant? I see certain dentures, certain abutments that come with O-rings. Can't we put an O-ring around it? And they'll make the thing so that it goes over the O-ring.
Okay.
Pardon?
So,
I'm not talking about anything. I don't do it. This is the guy that does it. So, but the point is, yes.
no, I don't think I was explaining it well. The guy had 2 implants on the mandibula, good fixing denture over it, but the Moses was not sticking to the denture. It slipped away from the denture, so the denture was keeping on above the implants, but
the implants, huh? Yeah, that's Gloria suggesting her answer. Her answer is make it softer so it's got more retention on it. Use it, monitor's not, what if we made it out of odontosil and a non-adjustable? Huh? What if she made her Moses in odontosil over the implants? It might stay better.
Have a piece of those softened plastic over the dentures.
No denture, just implants, right?
But how about those 2 implants?
no, I made the Moses over the denture.
Over the
that was
denture.
fixed over the implants.
Oh,
Right.
so then let's try it over the.
Can you put some grooves in the denture?
No, we're misunderstanding. She's making it.
She has an over denture.
No, yes, the implants are holding the denture. She made it over the denture like I suggested, and it's slipping off.
Slipping off. So
Then
can we
I'm-
put
then I'm
retention in the denture?
I'm suggesting maybe that's one way, but the other thing that's what you're suggesting, I guess, right?
Making the appliance directly onto the implant.
That's the other alternative.